Little
Okay,
moment.
ma'am. I am ready.
Yeah. Can I have someone to? No, it's not that he's speaking. Yes. All right. So if you're ready, I'm starting the timer.
I am ready,
All
ma'am.
right. Yes. Here is the question. Right. So if you've read and understood, kindly tell me what are your differential diagnosis for this case or this patient?
Differential diagnosis regard del case scenario. Familial polyposis adenomatous coli and hereditary non-polyposis colorectal cancer, and could be inflammatory bowel disease, and could be Gardner syndrome, and could be CA colon.
Okay, good. How would you think of going ahead and managing this patient? She has the largest polyp, which is 7 millimeter, and it's ulcerated. So what should be the, yes?
Yeah. The management after history and examination and investigation need routine full blood count and urea and electrolyte and liver function test and the CT scan and the sigmoidoscopy and take biopsy to confirm diagnosis, and the treatment after MDT meeting with the surgical doctor and the oncological doctor and radiological and pathological doctor and depend the management according to the staging of the and depict the site and the size of the polyp. Demand mainly surgery, could be laparoscopic or open surgery.
What do you see in this image? What is it?
Yeah, I am seeing multiple polyp for the colon. This
Yes.
is sigmoidoscopy reveal multiple polyp on the wall of the colon.
Okay. How should this patient be followed up?
What is, ma'am?
How should this patient be followed up? Surveillance.
Yeah, the surveillance by colonoscopy every 6 months and CT scan every 6 months for the CT scan for the abdomen and pelvis and brain and chest and full blood occult test and investigation as liver function test and ultrasound to any metastasis from as CA colon.
What is the pathogenesis of this condition?
The pathogenesis of
yes.
this
Yes.
Yes, this is familial polyposis adenomatous coli. This is autosomal dominant condition due to loss of the ABC tumor suppressor gene on long arm of the chromosome 5 lead to develop of 100 of adenoma, mainly tubular. This is the ABC tumor suppressor gene. This is responsible that encode a factor to regulate the WNT between the colonic epithelium by promote the formation of the complex that degrade L-beta-catenin. If the loss in the ABC tumor suppressor gene can lead to FAB.
What other genes are involved in this condition? Familial adenomatous polyposis.
Yeah, another gene, loss of the ABC tumor suppressor gene lead to hyperplasia, and KRAS oncogene mutation lead to dysplasia, and loss of the B53 tumor suppressor gene lead to adenocarcinoma.
Yes, very good. What are the types of cancer these genes can cause?
Adenocarcinoma lead to cancer colon.
Yes, okay. Oncogenes,
And
ESG3, yes.
yeah, another types of gene lead to cancer as stability gene and oncogene and the tumor suppressor gene.
Can you tell me what are the types of adenomas that you are aware of?
Yes, types of the non-neoplastic and as hamartomatous and metaplastic and inflammatory as pseudopolyp and ulcerative colitis and the neoplastic as phillus and the tubulophilus and the tubular.
What are the extracolonic FAPs?
What is, ma'am?
Extracolonic conditions?
Extracolonic condition could be ectodermal and endodermal and mesodermal.
Yes. Okay, how the patient is staged or how the tumor adenoma is graded?
Staging by Duke classification and
Yes.
TNM staging. As the Duke
Yes.
classification classified to four grade. Grade A confined to the mucosa, B through the muscle, and C to the lymph node, and D distant metastasis. And the TNM staging classified as TIS online mucosa, and T1 through the muscular mucosa extend to the submucosa, and T2 the submucosa extend to the muscularis propria, and the T3 through the muscularis propria and to the serosa, and T4 from the serosa and to the adjacent organ.
This patient also had endometriosis. What might be the cause for it?
The endometriosis because abnormal or overgrowth of tissue outside the uterus could be on the fallopian tube, could be in ovary and the tissue around the uterus and the other part of the body as the colon.
Can you define endometriosis?
The endometriosis,
Yes.
this is disease which tissue that normally grow outside the endometrium, grow outside the endometrium, like ovary and fallopian tube and tissue around the uterus.
Okay, can you define the term dysplasia?
Term dysplasia disorder, cellular growth characterized by pleomorphism, increase mitosis, and increase cytoplasmic ratio.
Can you explain the mechanism why this patient might feel pain?
What's, mom?
Why this patient might feel pain? She has endometriosis and she undergoes colonoscopy and she has polyps. Why would she experience pain?
Because due to fibrosis may occur at the site of the lesion and the peritoneal cavity lead to adhesion formation with subsequent intestinal obstruction and the obstruction of the
What are the risk factors to develop carcinoma colon?
The risk factor of the to develop cancer carcinoma risk factor more common in European than another countries. Another risk factor due to reduced exercise and high fat intake, alcoholic patient and smoker, and another as pre-malignant condition as familial polyposis, colorectal cancer, الفاب, and the hereditary non-polyposis colorectal cancer and Gardner syndrome and the desmoid syndrome, and could be cause genetic and the hereditary. This is all risk factor related to cancer colon.
Good. Okay, last question. Bella's gone. Looking at this picture, how would you grade this adenoma or this tumor? What would be the grading according to you? Yes.
The grading depends on the type of adenoma and the degree of the adenoma.
By just looking at it, can you tell which grade would that be? or the largest 7 millimeter would
Yeah,
be what? And it's ulcerated as well. So it would be according to Duke's classification, which one, or according to TNM? How would you grade it?
grade it could be a grade grade 2.
Grade 2, okay. Good. It says it's ulcerated. What do you understand by the term ulcerated? Can you define ulcer? What is ulcer?
The ulcer, this is break or discontinuity in the mucous membrane and the skin with loose surface of the tissue with disintegration and necrosis of the epithelial tissue.
Good. Very good. Excellent. Could answer everything. Yes, good. They are writing. Good. Yes. Segment membrane adhesion and obstruction. Okay. Yes. They are also saying B. Good. Excellent.
Thank you, ma'am.
Good. Yes. Anyone else want to add anything or want to give feedback? Yes. Should we move on? Yes. Yes. Yeah. Good. Excellent. Yeah. They are already your friend, Dr. Mohammed.
Thank you, all doctor.
Yeah.
Thank you, ma'am.
Tough. They are saying tough. They came late.
Yeah,
Okay. Yes.
yesterday I done assist with the consult surgery
Yeah.
colorectal cancer, sigmoidectomy.
Very good. Yes, Dr. Ishfaq.
Dr. Mohammed, can you please tell us what's the age, at what age we start the screening?
Yeah, I did ask him about the screening.
What's
But
up?
he
Screening protocol.
screening protocol again, and age, and when should you offer the patient surgery, because finally he's going to have surgery. You do have to operate him.
Screening before the surgery for operation.
Yes,
Yes,
yes.
please.
When will you start the screening? At what age should we go for the screening?
Yeah, the screening after history and examination and investigation and screening start at the age of the 12, and then done colectomy at 25 years old, and because mainly risk of the multiple or risk of the cancer 100% at the age of the 40.
If patient has a strong history like this patient had, would that be still the same age? You will start
Yeah,
screening. Yes. Yes.
yes. Yeah, screening need genetic counseling and screening by fecal occult blood test and another investigation as CT scan and tumor marker specific for the CA colon, and can be detected or diagnosed as Amsterdam criteria
Yes.
for or screening for the family.
Yes. Yes, Dr. Abhishek, agree. If diagnosis is done early, then yes, even surgery will be offered early. So, yes. Good. Right, should we move on? Dr. Ulfat, are you ready?